And I have the pleasure to introduce Dr. Rapcan, Robert Rapcan, who came all the way from Slovenia. He's all over the place. He's in Sweden, Czech Republic, Slovenia. He has great expertise in Percutaneous Transforaminal Disectomy, and he is part of our faculty for Gulf Pain School, teaching about all these modalities, innovative, futuristic, and I'm glad to have him with us to talk about this new armamentarium in our list of pain physicians. Please, Robert.
You realize it's going to be your friend forever, maybe? And I have this feeling when I met Bernard today, and when I saw his first presentation, I think the feeling is just continues. So, very nice presentation. And I think both of us, we are a little bit coming to the topic which is not 100% usual for pain medicine congresses, but I hope in a near future it will become more and more standard within pain congresses as well. And I also hope that spine surgeons will stop being angry with us when we are talking about this topic, because I hope we will show that we are competent to perform it. So I'm going to talk about percutaneous lumbar endoscopic discectomy as a new segment within pain physician portfolio. And this is my disclosure. And if I take it from the very beginning, we use more and more endoscopy within pain management procedures. We can do endoscopic facet joint, we can do SI joint under endoscopic vision. We can do endoscopic discectomy, we can still perform epiduroscopy, and we have seen on this congress other endoscopic indications. If you go to the diagnostic diagram, this is my simple internal diagram, and I don't want to torture you with details of this. I just want to say, to get a patient on the table for endoscopy requires a very good and very proper diagnostic algorithm. It's not good to do surgery on MRI only. It's very good to exclude all other pain generators and to get on the table someone who really needs to be on the table, and then we'll have a benefit from the procedure. So if you go to this therapeutic and diagnostic segments, you see that for transforaminal endoscopy, from the whole diagram, only those two small spaces are suitable for this. And then the main question is, can pain physician be as good as a spine surgeon for transforaminal or interlaminar pain surgery, endoscopic surgery? We have done some publication where we performed a study where we compared a very experienced endoscopic surgeon from spine surgery field with quite experienced pain physician. We did herniations at the lumbar levels from L1 up to L5S1, and the aim of this study was to compare clinical outcomes between interventional pain physician and a spine surgeon on transforaminal discectomy. We did 12 months follow-up. We compared leg pain, osseous disability. We did relative risk complications on 160 patients divided into two groups between pain physician and spine surgeon. And this is our results. Leg pain, this is a pain physician, this is a spine surgeon, this is after 1 year follow-up. You see no difference, equally good results. The same on back pain, equally good results. Osseous equally good results. When you go into complications, you see there is no significant difference between pain physician and spine surgeons. It's fun that spine surgeon performed one dura tear in this group and pain physician hasn't performed any. But I would not take it as a significant problem. So conclusion number one from this study is saying that maybe We did not discover any significant difference in both groups in the clinical outcomes during 12 months evaluation. There was no significant difference in reherniation in both groups. Our overall percentage of disc reherniation was 6.3, which is like normal in any kind of endoscopic or even open surgery environment. And then this is my internal conclusion number 2, and some of you can disagree with this. It's an appropriate method for pain physician if he is adequately trained. That's very important to say. Not every pain physician can do endoscopy. You need a proper training. Of course, pain physician must manage intraoperative bleeding. You cannot start screaming when you see in your epidural space start bleeding. You have to be able to manage it. Pain physician must manage postoperative complications as well. Pain, reherniations, dural puncture, discitis, wound infection. Maybe pain physician doesn't need to manage postoperative epidural hematoma or epidural abscess, because all the anesthesiologies with spine injections can cause the same problem, and they don't need necessarily to take care of it. And if we go to transforaminal approach, because this is something which has, in my opinion, advantages in interlaminar approach, because you don't damage, you don't destroy, you don't cause any damage on posterior segment of muscles, which is very good for some special groups like elite athletes or adolescents. I will show you a couple of slides. You can use system for targeting extraforaminal herniations, which is difficult with open surgery. You can do foraminal, lateral recess, anterior epidural space, and you can also take care of the posterior annulus, what Bernard was explaining in a previous presentation. Normally you access the foramen through the Cambin's triangle, but what is good about maximal instrumentation we're using, your target is superior articular process. So first you touch the bone and you drill through the bone to the foramen, and then this is decreasing the risk of damaging the exiting nerve and also giving you better orientation inside the foraminal and epidural space, because you carry on then with the under optic vision. So it's pretty safe, and also it gives you a chance to enlarge the foramen in case of foraminal stenosis. You need to get very good knowledge of anatomy. It's not just simple anatomy. You need to know a lot about transforaminal ligaments, small vessels, and small nerves inside the epidural space and foramen. When you're planning your access, you need to plan correctly, because with the transforaminal approach, if you don't plan correctly, you miss the target and your operation will be not successful. So you need to know if this is a disc herniation with a cranial propagation, caudal propagation, and according to this you have to plan your trajectory. It's a joystick philosophy, so if you are good with any joystick thing, you can do it very good on the patient as well. Then you have to plan also the position of the, according to the position of the disc herniation inside the epidural space. You have to know if the herniation is centrally, paracentrally, preforaminally, intraforaminally, extraforaminally, or you have to know about disc propagation as well, if it's grade 1, grade 2, grade 3. And according to all these things, you are planning your strategy how to access the protrusion or herniation or sequestration. I don't want to bother you with too much technical things. I just want to say those manual drills are a very good friend of you if you use it, because it's very natural for you to access foramen. You're using sort of Seldinger technique to get there, and the same technique you're using for drilling away the part of the superior articular process to make your method safe and to get where you need to get. The calculation how to do your trajectory, you can do it with different type of geometrical calculations, anatomical calculations, but the simplest way is to use your MRI and to plan your calculations according to your MRI. And then if someone tells you that it's impossible to take out a big herniation or herniation behind the vertebral body, it's not true. You can actually access anything. You just need to choose the correct technique how to do it. So for example, this type of herniation, you have to correctly plan your external marking, your skin entry point, and then you have to correctly place the first instrument, the needle, tomshidi, to come on the part of the superior articular process, where you are planning to come behind the vertebral body here. Then tomshidi is the first instrument where you really need to be very cautious. If you place this instrument correctly, the whole surgery will go perfectly. If you don't do it correctly with tomshidi, the whole surgery will be not successful. So you carry on, always apilateral, and then you start drilling the superior articular process up to normally 8 millimeters. In some special cases you use also 9 millimeters. Someone needs to make a phone call, no problem. And then you establish your working sleeve, go inside with the scope, go inside with the manual grasper, you grab the herniation. And some people, they ask me if I see something with the scope. So this is approximately what you see with the endoscopic view. It's not a bad picture. You really see what you need to see, all the structures very clearly, and you take out the herniation of any size. I get a question from my friends, if there is any procedure, if I have no chance to do any other procedure except for one for the rest of my life, what procedure I would choose? And I answer, I would choose the transforaminal endoscopy as the only one. I will do it because it's very effective and it gives the patient extremely good clinical results. I don't think there is any other procedure within pain physician portfolio with such a kind of concrete and good results. This is a part of our subgroup of patients, 470 patients we have evaluated with endoscopic discectomy at different levels, with also 1-year follow-up, watching osseous disability, low back pain, leg pain, and special questionnaire focused on quality of life. These are questions where you can see that we got very, very good results of 1-year follow-up. So I think the procedure is very good. And I will tell you a little bit more in a few more minutes. If you think about some other situations, you can use transforaminal endoscopy in. You also have a situation when you already had a patient with fusion, open surgery, and the patient comes to you with radicular pain. You do MRI and you don't see any reherniation. So what you will do? Of course, you can try all possible options like pulsed radial frequency, Rat's catheter, and so on and so on. And sometimes it works, sometimes it doesn't work. And why it doesn't work? I will show you one patient of mine. This is how you can access the foramen with transforaminal endoscopy, even on openly fused patient. And this is the picture from the foramen. This is adhesions tissue within the foramen. This tissue, I can guarantee you would never ever manage to treat with either Rat's catheter or pulsed radio frequency. And this tissue totally blocks neural structures and will cause pain similar to radicular pain. You need to be very cautious, take away the tissue, and the final result will be movement of the neural structures again. And patients under local anesthesia will tell you immediately on the surgical table, I don't have pain anymore. So this is the patient with L4-L5 situation, and now you see the movement of the neural structures. Then, Bernard has already explained everything about this topic. This is MRI, maybe nothing wrong. You see a little something on L4, L5, and you say, what can be wrong with this patient? Nothing. Unfortunately, the person was elite Swedish cross-country skier, requested elite training, a lot of back pain, no radicular pain, and the only option she was offered was fusion, which means the end of her elite sport career. So she came to our clinic and we did type of transforaminal endoscopy with thermal annuloplasty, with the posterior approach with the trigger flex, and also with the denervation of the sinovertebral and basivertebral nerve. You can do endoscopically this, maybe as effective as transocularly inside the vertebral body. Another special indication maybe you can find is adolescent disc herniation. This is 11 years old young lady. Her history is radicular pain at L5S1 dermatoma, paramedian extrusion as you have seen, clinical symptoms over 6 weeks, initial motor and sensory deficit, continuous pain, 24 hours a day, 7 days a week, worse at night. What is interesting about adolescent disc herniation is two things. Number one, they are very rare, 1.5 up to 3% of all the disc herniations. Number two, they don't heal spontaneously. 95–96% needs surgical interventions. Otherwise, they will have it for the rest of their life. Problems with the nerve, permanent nerve damage. And if you go to 11 years old lady with any kind of open surgery, the risk is very high. So that's why it's similar like with elite athletes. You need to avoid damage of the posterior segment, and transforaminal approach is maybe the best, despite there is no evidence because of too small number of patients proving it. Anyway, in this case, the lady this is just her previous medical history saying that she has no medical history except for gained 20 centimeters in 6 months. Yeah, and she was playing actively basketball. So that was her problem. We did transforaminal endoscopy, took it out. You see the incision with one suture. And the lady, after 5 months, on 5 months of follow-up, no medication, no clinical problems, back to basketball. So it's a very positive clinical result. We talk about complications because pain physicians maybe need to be afraid of complications or any kind of medical specialty. I would say, realistically, maybe the biggest problem is spondylodiscitis. If you do disc surgery, you will have it. You will not avoid it. You will have it, maybe not very often, but you will have it. I have 2–3 every year. Then you will have transient paresthesia, which is for a couple of weeks, maybe sometimes a couple of months, but will heal spontaneously. Intraoperative bleeding, you will manage. Durasect here, you don't do anything with it. Otherwise, you don't have any significant complications if you are competent. Of course, if you're not competent, you can place your instruments not inside the spinal canal, but to the lumbosacral plexus, blood vessels like aorta or abdominal viscera, and then you have complications, but this is not called complications, this is called incompetence. Radiation, it's not an issue. In interlaminar, not issue at all. In transforaminal, it's only becoming issue if you replace your competency with repeated X-ray because you think something has changed on your needle position if you do 10 more X-rays on it. But it will not change. You need to work with your instruments, not with your X-rays. But when you get a proper training and you are good at transforaminal approach, your time for radiation is very short. So, to sum up, finally the whole presentation, I would say transforaminal approach is a minimally invasive procedure, which is very suitable for pain physicians who are interventionalists and are able to access foramen on a daily basis. You do the procedure normally under local anesthesia, with or without sedation, depending on the mentality of your patient. You can expect fast recovery. You have wide indications, including recurrent herniations, also recurrent herniations after open surgery, extraforaminal herniations, more advanced, but very good indication for transforaminal surgery. And then you can also use this technique for decompression of foraminal stenosis, and discogenic pain treatment is also possible. Thank you very much for your attention and for your patience. You stay until the end. And this is a nice picture of Slovakian mountains. In case you are interested in visiting our country, you're welcome to be there.
Yes, please.
Thank you.
Great. Again, we will wait till the end of the session. It's all about spine decompression, and Bernard will take over with endoscopic spine decompression. What is the perspective of pain physician? And I saw Bernard at the beginning of your lecture, Robert, taking a picture of the slide where you said, are we better or are we bad as spine surgeon? So I think he has ideas about that. Bernard.